Okay, so let's dive into this case. What we have here is a frontal chest radiograph of a skeletally mature patient. At first glance, several abnormalities catch my eye. The most prominent feature is the presence of multiple nodules projected in the left lung, and notably, one large retrocardiac lesion. This large nodule measures several centimeters in diameter, and some of the nodules appear to show cavitation. That's always an important feature to take note of because it immediately starts steering my differential in a certain direction. Now, when I examine the hilum, I see that the left hilum is particularly bulky. It has an irregular outline, and I can't identify the normal hilar point. It's worth noting because hilar enlargement can be caused by a few things, most commonly lymphadenopathy or a mass. One other key finding is the bony destruction of the lateral aspect of the left clavicle. This destruction is pretty substantial, and it's extending into the soft tissues. There's disruption of the fat planes in the supraclavicular fossa, which suggests that there's likely a soft tissue mass component here. There are no other obvious bony destructive lesions that I can see, though I do spot old right-sided rib fractures. So when I pull all of these findings together, multiple pulmonary nodules, a bulky left hilum, and bony destruction of the clavicle, the most likely explanation is metastatic disease. Specifically, I'm thinking about metastases to the lungs, hilum, and skeletal system. The absence of the normal hilar structure really points towards metastatic lymphadenopathy, and the clavicular destruction, along with the nodules, aligns well with metastatic skeletal involvement. If we talk about possible primaries, given the osteolytic nature of the clavicular destruction and the lung nodules, metastatic bladder cancer jumps to mind. It's aggressive, often presents with both pulmonary and bone metastases, and fits well with this picture. Another possible primary could be bronchogenic carcinoma, which could also account for the lung findings and bony involvement. But given the absence of a central mass, bladder cancer seems more likely here. At this point, I would definitely recommend staging CT scans to get a better sense of the extent of disease, particularly to assess the mediastinum, abdomen, and pelvis for further metastatic spread, and to potentially locate the primary tumor if this is a first presentation. Now, thinking about how the Viva examiners might push me further, they might ask something like, what makes you think this is metastatic and not something else like an infection or an inflammatory process? To that I would explain, the cavitating nodules and the destructive bone lesions really point me towards a malignancy. While infections like TB or fungal infections can cause cavitation, they don't usually cause clavicular destruction in this way. Plus, the clustering of findings, both skeletal and pulmonary, sways me more toward metastatic disease, particularly from an aggressive primary like bladder cancer. Next, they might ask, why do you think the clavicle is involved here? I'd say the distal clavicle is a common site for metastatic spread, especially in cancers like bladder, breast, and lung cancer. The osteolytic nature of the destruction, combined with the pulmonary nodules, makes metastasis far more likely than a benign process like osteomyelitis or trauma. Then the examiners might follow up with, what other benign conditions could present with clavicular destruction? This is where I'd say, it's true that benign conditions like hyperparathyroidism, rheumatoid arthritis, or pycnodyssystosis could cause clavicular changes, but they'd usually have a different pattern, more systemic and not so focal. For instance, in hyperparathyroidism, I'd expect more generalized bony changes, not just isolated clavicular involvement. The aggressive focal nature of this lesion suggests a metastatic cause far more than any benign condition. At this point, the Viva examiners may test my ability to balance differentials. Could this be something like a primary bone tumor? I'd acknowledge that possibility and explain it's unlikely to be a primary bone tumor like an osteosarcoma or Ewing's sarcoma, because those typically present with more localized bone destruction, and we don't see the pattern of pulmonary nodules like this with primary bone tumors. Plus, the cavitation in the nodules and the bulkiness of the left hilum really push me away from a primary bone lesion. If they asked how I'd manage this case, I'd lay out a clear plan. I'd recommend an urgent CT scan of the chest, abdomen, and pelvis to stage the disease and search for the primary. I'd also involve oncology early on because Based on these findings, the patient is likely dealing with an advanced stage of metastatic cancer. A PET scan could further delineate the extent of disease, especially to assess for mediastinal involvement and any other areas of active disease. And if they wanted to know more about the clavicle, perhaps asking, what's the significance of the absence of the distal clavicle? I'd explain. The distal clavicle is often one of the first areas to show signs of metastatic spread. The fact that it's missing here suggests an aggressive destructive process that's highly likely to be metastatic in nature. The absence of the clavicle, in combination with the pulmonary findings, strongly suggests that this patient has a widespread metastatic malignancy. To sum up, I'd conclude, the constellation of findings, pulmonary nodules, bulky hilum, and osteolytic destruction of the clavicle, leads me to believe that this is a case of metastatic disease, most likely from bladder cancer. The next step would be to confirm the extent of disease with staging CT and potentially PET imaging. Wrapping it up, I'd say, if you found this case breakdown helpful, remember to subscribe to Radiology Made Easy. And if you've encountered similar cases or have questions, drop a comment below. Let's keep learning together.